Thank you, Siobhan. So inspiring. Okay. Just take a moment. We're coming up to Q&A. Seamus, I know you're not staying for afternoon tea, and I asked that purposely just in case anybody has anything specific that they'd like to ask Professor Seamus before he goes. Siobhan, you're here for afternoon tea, so yeah. And there will be another opportunity within the Positive Living group online in November to listen to Siobhan again. And just to go through everything in a little slower motion, I think. Well done. Such a pace, and well done, Seamus, too, for a huge contribution to, you know, the research that's gone on over many years in your career to cancer, but breast cancer in particular. I know it's a real passion for you. And Louise, thank you for being here too. So I guess if anybody has any questions, I think you might need to stand up because they probably won't see you sitting behind this desk here. Does anybody have any questions for the morning panel?
It's not so much a question, it's just something else when you were going through the results there, is that I never really understood when to go to my oncologist and when to go to my GP. That if I was having trouble with, you know, needing sex or something like that, where did I go? People who have been healthy the majority of their life, they don't actually understand how the health system works at all and when to go where.
No, I just want people to hear it back. I'm going to take that because I had the same experience actually, and I'm supposed to know about the health system, but I went to my GP after I was diagnosed metastatic breast, and I said to her, I've been a long time, and all my children have been to the same GP, she's phenomenal. And I just said, exactly like you said, Rosanna, can you just tell me who do I go to? Do I go to the nurse or chemo nurse, consultant medical oncologist, consultant radiation oncologist, X or Y, Z GP? And honestly, what she said to me was, actually, Siobhan, we're not experts in metastatic cancer. In other words, we cannot really help you. So your care is in the hands of the medical oncologists. And again, that puts a bit of pressure on the medical oncologists, but that's basically where the GPs here are currently. I don't know if you want to add to that.
Very good question. I think the first thing is dividing responsibility is no responsibility, and I think it can be very difficult when you're caught up in the system. During COVID, I was asked to go on Morning Ireland to do an interview, and this woman that was on before me, and I thought I knew her from before because of working with cancer trials Ireland. The name is not a common name in the parish of Cork, and it was Siobhan explaining her when she had become a patient, you know, when the cancer came back, and the challenges of that self-navigation and the huge challenges. And it was very sobering to listen to her because we hadn't met in at least well over a decade. And it really brought it home. Her story, I mean, she owned the radio interview, as you can probably imagine, and her story really resonated in terms of the challenges. And I think, who do I call when I need to talk to somebody is a huge problem in our health system, because there's so many different places. And you want to call your liaison nurse, but she's maybe on leave that day. You can't get through to the secretary because they may not be at the desk. And I one of the things that I felt was a potential huge outcome from Siobhan's study was that it would humanize people. You know, it would quantify and humanize the experience of patients in the system, and then reverse it into the system to make it better. That it would start a discussion about what would the optimum situation for a patient with cancer trying to deal with this system be. You know, that if they need to make a call, where do they go? That you have a standardized, that our survey, our survey would catalyze that discussion, and that would trickle down to other cancer types and other metastatic cancer types. We did a survey of patients with metastatic breast cancer in 2014 as well, at 2 cancer trials Ireland with 500 patients. And that was done really because we had a Cadillac service for people who were diagnosed and a Chevrolet service for people where the cancer came back. And we had no resource and no liaison nurses, and we used that to advocate for more services. But it took that survey, for instance, in Cork, to get a liaison nurse. We had 9 nurses, individuals for patients with newly diagnosed breast cancer, but none for people where the cancer came back, where this was going to be a long event rather than, you know, a self-limiting illness, which is going to be very challenging but over. So I think that it will be lost. I'm hoping that now we're at in the weed stage with the survey in terms of the healthcare profession of using it to motivate change. So we've met with Louise and our colleagues in the Cancer Control Programme, but it's clear that we need to meet with the people in the Department of Health because ultimately they're the game changers in this. And so that's where things are next. The paper and the presentations are important. It's not just getting up, traveling to a meeting, but it gives credibility to the study. We've also developed an infogram that you see in that as well, because people, you know, that when you go to, it's exactly as Siobhan says, when you go to a meeting, the first, you know, you're wrestling with the person's iPhone, and you want one message. So we developed an infogram, which is one message, which is socially available on social media, and it can be clearly visible. And I agree with Siobhan completely in terms of number 10 is the most important. And if you get number 10, the rest will trickle up. You have your service line of who your GP calls or who you call when you need to call. So that's the ambition, and I guess the heavy lifting now in the next year for us as a community. And I really respect Siobhan's plans for succession, and I also like the other comment, many backgrounds make better teams, that's the next phase really of engagement with the stakeholders, because ultimately we need them to resource this and to put in guidelines to make it happen. And that's the biggest thing now. But quantifying having data to say this is the problem, patients have spoken, and you know, this is what happens next, what are you going to do? I also think that the timing of this is important because the current cancer strategy ends soon. So the next line of thing is going to be the next cancer strategy. And if it isn't in the strategy, it doesn't happen. And certainly having the data in anticipation of the strategy, that's what we really need, and that's what's important here. But I would just add the many here, the bigger the community, the bigger the voice, the more disparate the voice, the different networks you have, the different influences you have, that's really important, I think. And that's probably the next challenge as a community with the really important cancer charities, with the cancer support houses, what happens next and how do we make it happen? Because as you can, getting that buy-in, people in the government will listen and they'll nod their heads and, they'll be all, yeah. But actually translating that into something tangible in the clinics now is what we really need.
I'm just interested, actually, there's a lot of information that was given today, and looking forward to looking at it in detail. But kind of relatively new in the metastatic diagnosis, and terrified of Dr. Google. So I try to avoid it. Can't always, never like what I see. But how do we go down looking at all these new things? That, like, I have previously been involved in a trial that unfortunately, didn't do as well as they were hoping it was going to do, so I'm still back here again. But how do we go, what recommendations for that? Do we still try to do some of our own research to see what's out there, or should we stay back and avoid just picking on the wrong page and seeing something that sends you down into a deep dark hole? No, sorry.
So I'll take it first, but I'm going to give this to Siobhan as well. So
we have also struggled with the internet and knowing what's, you know, what's reliable and what's safe. And there are some curated websites. Macmillan is very good. The American Society of Clinical Oncology is good, but some of it isn't. And the Irish Cancer Society and other are good and very helpful as well. And the problem is when you go beyond them and kind of reach out, you can go down a rabbit hole, and it's very. I mean, there's a lot of medical misinformation on the internet, and the internet search companies have no, you know, they don't curate what they've no authority, you know, they don't want an authority to what they curate in terms of reliability. I love when patients research, because the more empowered the patient you have with you, the better their care will be. I think some people are threatened by it, but that's, you know, but I think that shouldn't be the case. I mean, I think the care is a partnership. And I also feel that the more empowered and engaged and aware patients are, the better, you know, it trickles up in terms of advocacy for others in the community. So, but I think we all wrestle with what's on Dr. Google. So I encourage people to bring it with them and discuss it, and we can say what's good and bad, because we all wrestle with the same thing. And I think that we all wrestle with, you know, if a study is positive, if there's a good result with it, there's a huge publicity associated with it. But if there's a negative study with the same drug, it won't be in the same journal ranking. It won't get the same degree of publicity. So we also wrestle with what's relevant and not relevant, because it isn't always, the medical literature isn't always balanced. That's why the guideline meetings are important, because they give a better readout. They allow that kind of synthesis to occur that's needed. So the guideline documents are a helpful first part, particularly the metastatic guidelines, because they're very much there are significant number of patient advocates on the paper, and so it's written with that through that lens. So we find that really helpful from that point of view. Sure.
Well, you can guess what I'm going to say, which is, you know, knowledge is power. I will, to my dying breath, say knowledge is power. I appreciate those of you from a non-scientific, non-healthcare background might be overwhelmed, but like, as I always say, it's just another language, okay? And you need to understand the language first. So if you can, you know, there's some great glossaries out there. Seamus said, I'd refer you number one, and any questions you have in terms of treatments, go to the ABC guidelines. They're phenomenal. That's the Advanced Breast Care Guidelines. They've just published their latest 7th version this year. So that's my number one go-to source. The second thing is, you know, I remember again, 20 years ago being told, you know, as patients not to go near Dr. Google. That day is gone. Actually, I think we're way past that. What is important to understand as patients is the context, okay? Wherever you get your information from, be it, you know, patient forums or A said to C, B said to C, or, you know, the Sun newspaper, wherever you get it from, you have to understand the context of what they're saying. So who's saying it? Has that been published? Is this also referenced in the ABC guidelines? Because, you know, the ABC guidelines are broader than just medical treatments. So you need to almost verify yourself where that data is coming from, because it's not always true. There's the Wild West out there, particularly in metastatic cancers, because, you know, they want to sell us hope. You know, sometimes that's hope equals wacky treatments. So just be very careful. So you need to understand the context. So what I would suggest, and always say to people when they're first starting out, go to ABC guidelines first. Then speak to other patients and, you know, people within your healthcare team about the context of all of this. The first because you need to get to the right questions. Actually, when you're skilled as a patient and you're good at what you're doing as a patient, asking the right questions is actually critical. Now, in order to ask the right question, you have to have the information. So going in blind to a meeting, I don't believe ultimately is in our favor, particularly when we get to later and later stages in our treatment, when there's some really tough decisions to be made. So I think you need to understand what the journey ahead for you is going to look like, insofar as we know there's big gaps. You have to understand there's big gaps in our data set, as I've outlined. So it's not always perfect data, but you need to understand that and the context, and speak to all of us, because actually there's some really huge the most knowledgeable metastatic breast cancer patient I know actually is Anne McBride, and she's an accountant. So it's not just all about the science.
Well said, Siobhan, thank you so much. I think we're probably going to have to close off now because we're running late, but most of us are around for our afternoon tea, so if there's any questions, but equally if there's anything you want to ask that with Professor Seamus, we can pass it on next week maybe, once you come back from London. So a big hand for Louise Mullen. So we need to take if we could have you all back to your seats, please. I know it's really important to talk. And in fact, the Irish Hospice Foundation would say it's time to talk. So that's what we're here. We're going to talk. And I have great pleasure in introducing Dr. Marie Keating Leary, who is a consultant in palliative medicine at Marymount Hospital and Hospice, and in Cork University Hospital and Mallow General Hospital. And she's been there since 2015. She's a senior lecturer within UCC as well. A graduate of University College Cork, Mary Jane completed her specialist palliative medicine training with the RCPI between 2009 and 12. She completed a clinical fellowship in both paediatric palliative care and early integrated ambulatory palliative care with the University of British Columbia in Canada from 2012 to 2013. She was co-chairperson of the Fraser Health Authority Hospice and End of Life Programme between 2014 and 16, and was appointed project lead of the National Palliative Care Choosing Wisely campaign for Canada. Choosing Wisely campaign for Canada. Okay. Dr. O'Leary is a member of the Executive Board of Marymount University Hospital and Hospice and the medical lead for the palliative care services in Cork. So Mary Jane, you're very welcome today. I don't think you've been with us here in the Marie Keating before, but we're delighted to have you. And we're going to talk about a subject that's very dear to our hearts here, palliative care, but probably more importantly, early referral to palliative care. So over to you, Mary Jane. Thank you.
My slides have disappeared. Perfect.
Just a little technical hitch. Happen. No, it's not going into.
That's okay.
Oh. Down for some reason. I'll let the expert at it.
There we go. That's better. Great. Thank you, Helen, for that lovely introduction, and huge thank you for the very, very kind invitation. It's an absolute privilege to speak with you all today. Firstly, I think I certainly want to commend Siobhan on the incredible work that she has done. I think any of us who've partaken or conducted any form of research would be quite astonished by what you've managed to accomplish in such a short space of time. And I know you had a great team around you, but you were the one from the very beginning who was driving it all, who was motivating it, who was organising those meetings and keeping on top of everything. So massive congratulations on the piece of work that you managed to, as I said, accomplish in such a short space of time. And I suppose on the impact that that is having and will having on patient care is really, really commendable. So as Helen introduced me, I'm a palliative care consultant in Cork, and our posts are a little bit different to other consultant posts in that we're spread out right around the acute hospitals in the community in a way that hopes to kind of follow the patient on their journey wherever they need to be or wherever they choose to be at any given time during their illness course or during their illness trajectory. So I work at the Cork University Hospital, Mallow Hospital. I cover the North Cork community area community team and work back at base at Marymount Hospice. operating on the mantra that we follow, as I said, the patients where they need to be or choose to be at any given time. So today I want to talk to you about palliative care in 2024. What are we actually talking about? What our services look like? The clinical evidence to support integrating palliative care early for patients in their illness trajectory, but the huge challenges going along with that and delivering an integrated palliative care oncology care model. How can we, as healthcare providers, what can we do at this point in time to improve that? So originally, when I was putting my slides together, I very quickly included this slide to say that I had no conflict of interest to declare. And then I remembered my past and that I was a very, very avid Boyzone fan, in particular Ronan Keating, and may have followed him around the country, the world, and here I am bopping away to his songs with my sisters a number of years ago in Croke Park. So I'm not sure whether it's conflict of interest or confession, but sure. So palliative care, what are we actually talking about in 2024? So when I Google, again, preparing for the talk today, I decided to Google image. Well, what is Google image telling us about what palliative care is about? And you see lovely images that are portrayed, people smiling, families together, people holding hands, lots of hearts. So really kind of pleasant pages that await you. But in reality, we know for patients and for the public, it's a very, very different perception that they have of palliative care and what palliative care means. And it often instills fear and the fear that the hope is gone, that there's nothing more that can be done in patients when the words palliative care are mentioned. So last year we undertook a study with UCC looking at the communication experiences. So why is this? Well, how are patients being introduced to our service? And what are their feelings when palliative care is mentioned to them? Overwhelmingly, people responded saying, you know, it did instill kind of feelings of hopelessness. God, what does this mean? Does that mean I'm near the end? Does that mean I'm running out of options? What does this actually mean for me? And got really, really terrified when they were introduced initially to the services. But very, very interestingly, the overwhelming majority of them also said if they had to change something after being involved with the palliative care services, they would change it and request to be referred to the service earlier, once they fully understood what the service was actually all about. So trying to explain to you what exactly the essence of palliative care is, I don't think we can go any further, but go backwards and look at the history of palliative care and the influence that this lady, Dame Cicely Saunders, made to the specialty in the 60s and 70s. Because the essence of what we do, even though where we deliver it and when we deliver it might have changed, the essence of what we do has not changed since her days and since as I said, the impact that she made on the specialty. So I might take a moment just to tell you a little bit about her kind of fascinating story and how the first hospice in London was opened, St. Christopher's Hospice. So Cicely was born into a rather privileged background in 1918 and studied politics and philosophies and economics at Oxford University. But then the war broke out and Cicely decided she wanted to help people. Much to the disgust of her father, she decided to study nursing at St. Thomas's Hospital. Her nursing career was short-lived. She had a back injury, so then decided that she would go on and study social work to become a social worker. But Cicely still felt a little bit undervalued. She felt she could contribute a little bit more. So she said to one of her surgical colleagues one day, but I feel like I'm not doing enough. I feel like I want to contribute more to patient care. And his advice to her was to go study medicine, which she's a little bit perplexed by. He said, go study medicine because it is the doctors that neglect the dying. So indeed she did. And through her workings with patients that were terminally ill, Cicely quickly realized that people needed a space to be themselves. She said, I realized that we not need only better pain control, but better overall care. We need a much more patient-centered model. And so grew the philosophy of palliative care, the philosophy of person-centered, patient-centered, holistic care. It considers the physical, psychological, spiritual needs of a person and considers external factors such as care settings, environment, and surrounding community to ensure we deliver the best type of care to a patient. I think she summarized this type of care because we all talk about patient-centered care, holistic care. What does that actually mean in practice? And I love her quote. Sadness is appropriate and should be faced and shared. It calls for a listener rather than for drugs, although a combination of the two may help to lift an inhibiting load and enable a patient to tackle problems that had seemed unmanageable. When such treatment is carefully assessed and reviewed, this is not to manipulate the mind, but to give it greater freedom and strength in facing reality, particularly pertinent, I think, to the patients facing a journey, an unknown, uncertain journey, living and trying to live their best life with advanced metastatic breast cancer. So the essence of palliative care hasn't changed since Marymount Hospice opened over 100 years ago, since Cicely Saunders first opened the first hospice in the 60s. The essence of what we do hasn't changed. But indeed, the timing and the introduction of palliative care has changed, and the setting of where we deliver palliative care has changed. So you can see the first graph at the very top represents the old historical model of palliative care coming in at the very end, in the last, sometimes even only in the last days of life, sometimes in the last weeks of life, to care for people when all treatment had stopped. And then we began to realize, as patients were living longer with cancer, as treatments were getting better, that actually these people were living with problems much earlier on than in the terminal phase of their illness. They were living with the symptoms from symptom burden from their cancer itself, from the treatments they were getting, and they were living with all the psychosocial complexities that illness and treatment was causing them. And so palliative care began to get involved much earlier on. And the lower graph, I think, probably represents the type of care we're delivering to patients now, in that we're dipping in and out as patients need it. We don't have the resource to follow every patient living with a metastatic cancer. So what we're trying to do is identify people who really need the service, particularly at the times in their life and in their illness journey that they really need us. So we'll, in times of high symptom burden, we'll get really, really involved. And then as the patient recovers and does well with their treatment, we'll dip out. And then we leave it up to the oncologist, the GP. And then if things become problematic again, become involved in their care. So this dipping in and out of care, of a patient's care when and as needed. So just to try and, I suppose, to capture the essence of what the palliative care service is all about. If we look at the evolution of palliative care, as I've already mentioned, Cicely Saunders, there was Val Vermont, who was very, very influential in Canada. But the other person that I want to highlight is Eduardo Barrera. He is a clinician, palliative care consultant, consultant at the supportive care service in MD Anderson in Texas. They've actually changed their name from palliative care to supportive care because of the, I suppose, the feelings that people have with the terminology that's used. And he's published over 600 journals looking at the impact, particularly on the patient-doctor relationship and the patient-doctor interaction. We were very privileged to have Eduardo speak at our conference in Marymount Hospice this time last year, actually. And I think he really epitomizes what we do and summarized really, really nicely what we do in this slide. He described in his very, very strong Italian accent, he's living in America, but he's got a very, very strong Italian accent, and I won't try to mimic him. But he described that we all have urgent things in our life. We all have really important things in our life, and you can see that in the red and the blue. But if we don't address the urgent things, we'll never get to address the important things. And our job as palliative care doctors and palliative care teams looking after you living with an illness is to progressively remove the red, so the very severe physical symptoms, the less severe orange symptoms, to tackle the green and allow you to focus on the blue. The things that are important in life, the things that really matter to you, in helping you to live as full a life as possible for as long as possible. And I think that really epitomizes the essence of what holistic care is all about. So what's the clinical evidence to supporting integrating palliative care much earlier in a patient's illness journey? So I think we can all agree that it's a changing landscape in terms of when palliative care are getting involved. But what's the evidence behind it, and why is this happening? So again, just to focus the mind on the results, the really pertinent results that Siobhan has already highlighted. I'm going to refer to it as Siobhan's survey from now on, if that's okay. Is that okay with you, Siobhan? It's Siobhan's survey, which is really, really nicely demonstrated and highlighted the really important things that ye feel as patients living with metastatic breast cancer in Ireland are not being tackled, the gaps in the care and where your needs are not being met. And the majority of this is around information. Information around your illness, treatments, information around your prognosis, and overwhelmingly, as Siobhan pointed out, the issues that you're reporting with your mental health and the impact this is having on your mental health and on your concerns around your fertility and your sexuality. Really, really positively, though, I have to say it was absolutely amazing to see how open people were with being referred to the service. So just keep these thoughts in your mind as I go on to look at what's the evidence. So again, I don't think I can speak about the clinical evidence without mentioning a really, really important researcher, Jennifer Temmel. And Jennifer Temmel published one of the biggest landmark journals in palliative care back in 2010 in the New England Journal of Medicine. Jennifer Temmel is actually a medical oncologist working in Mass General, but has a huge interest in early integration of palliative care in a patient's illness journey. So again, we were very privileged to have Jennifer join us last year as well at the Marymount conference in Páirc Uí Chaoimh. And just to give you a little bit of a summary of this paper, so early palliative care for patients with metastatic non-small cell lung cancer. So what Jennifer Temmel and her colleagues did at Mass General was that they randomized over 150 patients to receive their standard oncology care. And then they randomized the other half to receive standard oncology care with palliative care at the very outset of their diagnosis. These were well patients, fully independent, fully ambulatory, receiving active cancer treatments. So what was the impact? The impact was quite profound in terms of their improved quality of life. They had better mood symptoms, reported less depressive symptoms. But really, really surprisingly to many of the researchers, they also had a survival advantage, despite getting less aggressive systemic cancer treatment. Now, the landscape of metastatic lung cancer has changed a lot over the last 15 years since this study was published, but 3 years back then in the life of a patient living with, 3 months, which is the survival advantage for patients living with an advanced lung cancer, was huge. One of my colleagues, I'm sure most of you will be familiar with, but a lot of the immunotherapies have an IMAB at the end of them, and one of my oncology colleagues suggested that we needed to, after this study was published, that we needed to change our name from palliative care to palliative care IMAB. So Jennifer went on to look at a kind of more heterogeneous group of patients with lung cancer and also with gastrointestinal cancer, and again randomized them to receive either palliative care, standard oncology care alone, or standard care with oncology care. And again demonstrated the impact in terms of fewer symptoms, less depressive symptoms, better quality of life, but also better understanding of their illness and better understanding of their prognosis. It also showed that integrated palliative care model had improved patients' ability to cope with their prognosis and enhanced their communication with clinicians about end-of-life care preferences. Another, I suppose, very influential researcher in the palliative care literature is Camilla Zimmerman, who operates out of a very integrated palliative care oncology centre in Princess Margaret in Toronto. So Camilla and her colleagues decided to look at, again, a bigger heterogeneous group, so a huge, more varied group of patients living with solid tumours, over 461 patients. They underwent cluster randomization and partial blinding. And these patients, again, were very well patients, ambulatory patients receiving active treatment in and out to the cancer centre, and attended their oncologist, but concurrently attended their palliative care physician. They couldn't look at overall survival in this because one of the inclusion criteria was estimated prognosis. So again, these patients were randomized to receive standard oncology care or standard oncology care with palliative care. And again, very positively, showing the results of improved quality of life, lower symptom burden. And interestingly, she looked at patient and caregiver satisfaction with their care. And again, these patients reported and the caregivers reported better satisfaction with the care that they were being delivered. So this is a very small snippet of a huge body of literature that's growing year on year and really stemmed from the Jennifer Temmel study back in 2010. One other study which I should have mentioned, given Siobhan, the results from Siobhan's survey, was also David Hugh and Edward Barrera in MD Anderson looked at patients, again, early patients referred to the service versus the standard oncology care alone. And actually they had fewer ED presentations, which I thought was very interesting because the Americans are very interested in health economics and what's good value for money in terms of driving on resources and getting funding. So fewer ED admissions for patients that were referred to palliative care earlier in their illness trajectory. So again, to summarize the clinical evidence, palliative care enhances quality of life. It increases the use of adaptive coping strategies, lowers symptoms of depression, fosters better prognostic awareness, improves communication about end-of-life care preferences, leads to earlier initiation of hospice services, and decreases caregiver stress. So again, just to revert back to our survey that we've completed here in Ireland, relevant to the patients living with metastatic breast cancer in Ireland, all the things that we've identified, that ye have identified in this survey are tackled or we have shown in clinical studies can be relieved and can be eliminated with earlier intervention with palliative care. So really, really interesting there to see the overlap between the needs of the patients and what palliative care has shown to do. So I don't think the question is, should we deliver palliative care, but how? How we should deliver palliative care early in an integrated fashion as best we can with the resources that we currently have. And what can we do to improve? So again, just kind of following on from the thoughts of Professor Reilly earlier on and indeed Siobhan and Helen, there's huge challenges facing healthcare professionals, particularly oncologists in 2024 with emerging therapies and immunotherapies, as we've heard so much about from Professor Reilly a little bit earlier on. We know the knowledge is expanding faster than our ability to apply it. The doubling of medical knowledge increased from 50 years in 1950 to 73 days in 2020. Expanding treatment options have led to growing complexity of care and increasing risk as every point in the process of care can contain an inherent risk. So huge challenges for your oncologist, for your radiation oncologist, for the team of healthcare professionals looking after you and trying to decide what's best for you in your cancer treatment. Just a slight little bit of overlap from my colleague, Professor O'Reilly. That's the challenges our healthcare professionals face, but we can't even begin to imagine what our patients living with breast cancer face in terms of the challenges, the complexities of their care, the increased number of toxicities with treatments, the decisions around what's best in terms of treatment, and the need to, I suppose, another compelling reason to ensure we're utilising resources as effectively as possible to reach those that need the care most, to support them through their cancer journey, to help them with a more shared decision-making model. So early palliative care integration with standard oncology care is now widely endorsed from many organisations, from our own cancer strategy here in Ireland, but there are so many challenges with implementing this newer standard of care. And what are the biggest challenges and how do we overcome them? So again, back to our colleague Eduardo Barrera and David Hugh in MD Anderson, who've published widely on this, and how with the resources that we currently have, are we going to change the system so that we reach more people, so that we deliver more effective care to a much growing number of needy or patients that need the support. So you'll see here the diagram on the left-hand side of the screen depicts the more historical traditional models of how we operate. We can see our current models tend to be siloed, less integrated. So we need to look at an overhaul in the systems that we currently operate in so that we can deliver a much more integrated, supportive department to our patients. And again, Eduardo and David Hugh have published extensively on this, the need for systemic screening And again, in Siobhan's presentation earlier, she alluded to the fact it can't be an ad hoc referral to the service. It needs to be more systemic thinking in terms of a triage process, an automatic referral if and when the patient needs it. We need to think of the time toxicities and consolidate appointments for patients. We need a unified approach and a much more integrated service so that we can deliver this care more efficiently and effectively. Of course, we pride ourselves in palliative care on delivering a person-centered approach, a patient-centered approach, and we have to recognise that one size doesn't fit all. So how do we incorporate within our systems, so that we have a model that can be adapted to suit the needs of the individual at any given time along their illness journey? So personal palliative care, what does that look like? What should that look like? So what are the things we need to ask ourselves? When is the right time for patients? What is the right team to deliver this service? And where is the right place? And looking at our existing models, what do we need to do to change our models to make sure we're asking these 3 questions for each individual patient that we see on a daily basis? So when is the right time? So again, we need more systematic screening systems, trigger referral systems, so that we don't rely on ad hoc referrals. We need to identify patients at a time of need to determine when to introduce or when to intensify the palliative care services for them. And that's just a sample that came from a colleague, Joanne Droney, that I worked with from the Royal Marsden in terms of what they're looking at in terms of trigger referral systems to improve referral to the service. And what is the right team? And this diagram here is what we're striving to achieve for our own department and our day services department at Marymount Hospice, to ensure that we're moving away from the kind of more historical model of the nurse-doctor based model, but looking to the more holistic care to ensure that we're delivering the person-centered care that Cicely Saunders talked about so many years ago. We're looking at creating a much more bespoke model so that we can tailor to specific needs of individual patients that are entering department. We're looking at developing living well with programs so that you can come in. You don't need to see the nurse or doctor that day. You can decide to opt in for a meeting with the art therapist or the music therapist, or indeed engage in class physiotherapy sessions. So a much more bespoke model to suit the individual, all housed in the one centre. So where is the right place? So again, historically, traditional models of palliative care focused very much on patients that were less well, patients that needed inpatient hospice care, patients that were dying in the acute hospitals, and indeed patients that were living at home and unable to leave their house. So we're looking at much more dynamic models where people can attend ambulatory care centres and decide on what they need at a given time, as I've already alluded to. We need to work much more closely with our colleagues, our GP colleagues, our oncology colleagues, to ensure that this care is more integrated, that we're not burdening people with having 6 or 7 different appointments to attend, and how can we do this in a much more collaborative manner. So where is the right place? Again, if we look at the evolution of palliative care and how services changed, another huge impact on our service in particular has been the onset of COVID, because it made us have to change the existing model that we had in place for years overnight. Even though we think of all the negative impacts that COVID had brought on us, COVID actually brought a lot of positive change too, in terms of realizing there are more effective and efficient models of care, and how we can deliver more efficient and effective models of care. So if we look at where the right place is for some of our patients, what are the barriers to in-person palliative care? So it's very, very time consuming. These patients are already attending multiple oncology appointments, as Siobhan alluded to. They're going to see their psycho-oncologist. They need to fit in that physio session. They need to go get their bloods checked by their clinical nurse specialist. So it's a huge addition on top of a very stretched time frame for patients. And then we need to look at what are the palliative care barriers to delivering this constant face-to-face kind of interaction with patients. So there aren't enough resources currently, insufficient numbers of clinicians, inadequate resources, and we're constantly trying to balance the needs of the very, very unwell with the the more ambulatory patients with still huge need. So then we started to look at how could we design a telemedicine service, and can telehealth using video visits overcome many of these barriers? And indeed it can. And it is now framed part of our service, part of our automatic service in Marymount. I had a patient the other day who over the last 6 months had nurses visiting her home, and we gave her the option to attend a video consultation instead. And she said, "Oh, thank goodness, at least I won't have to tidy my house for this time." So again, it's kind of re-looking at the model of care that we're delivering in hospice ourselves, thinking of the individual patient. Would a telehealth consultation with their CNS or their consultant suffice, rather than bringing them into the building? We've also introduced a number of years ago, actually, FAB classes. So these are fatigue and breathlessness classes. They're a 6-week program run by our physio team, where patients attend twice a week. Again, pre-COVID, it was always automatically in person, and if you couldn't attend in person, then you couldn't attend. But since COVID, we've now introduced an in-person virtual model. So if you're feeling well enough on Tuesday, you come in on Tuesday in person. But actually Thursday, if your husband has gone to work and you don't have a spin, or you don't feel like leaving the house, you can do it virtually. So again, a much more adaptive model to suit the individuals. And again, when it comes to telehealth, we've examined the role of our community nurses. They see on average 3 to 4 patients when they're out and about on the road, face to face. Then when we looked at the activity levels of our nurses that were in the telehealth rooms delivering telehealth, they could see 8 to 10 patients. So a huge amount of improved productivity and efficiency in terms of the service that we were delivering. So we had a telehealth fellow join our team last year, and she looked at patient satisfaction, because we always have this feeling, oh, I'm not sure, I think I'd prefer to see somebody face to face. I feel like I'm getting getting better value for our time. So she decided to look at what the patient satisfaction was with these telehealth consultations. And the majority, 93% of patients, felt very, very satisfied with their video consultations. All patients felt able to communicate what they wanted to say. The majority felt comfortable when asking questions, and the minority, only 16%, were dissatisfied with any aspect of the care that they were delivered. And I said, a much more efficient, effective way to allow us to reach many more patients, and indeed much easier in terms of the time toxicity associated with the payments for our patients. So to summarize the role of early palliative care for patients with cancers, we know it's established and we know it's now the gold standard, but how do we implement it effectively? While the data from published trials is compelling, implementing these care models can be challenging, and current models may not be sufficiently tailored or patient-centred to best meet the needs of patients and their families. So we do need further research to focus on developing more patient-centred and scalable palliative care service models to increase access that is an essential core component to the care delivered to patients living with serious cancers. I'd like to moment, if I can, to share a little story of a patient that we cared for a few years ago now. This is the story of Catherine. Catherine is a 36-year-old mother of 2. So I'd like to borrow a phrase from a recent book that I read, when breath becomes air. When the oncologist referred to the introduction of palliative care services, not as the beginning of the end, but rather the end of the beginning. Its subtle play on words was very, very powerful. The end of the beginning and the start of a new journey. So this is the start of Catherine's new journey. Catherine was 36, diagnosed with a metastatic breast cancer when she first came to Marymount in the inpatient unit. She was bedbound in terrible pain at home, but had put off coming for several weeks because she was afraid. Afraid, as she put it herself, because there's only one way out of Marymount. She stayed for weeks. We fixed her pain. She got back on her feet. She took art classes and went home with her first painting for her newly decorated sitting room. Life got back to normal, and our community palliative care services kept an eye on her. She attended our FAB classes on a weekly basis for a period of 3 months, which she enjoyed tremendously. She wanted to tell people not to be afraid of Marymount and agreed to be filmed for teaching purposes and gave us permission to speak about her situation and her unique story. Thus began a new phase of Catherine's life. She embraced that new beginning, and each time life threw her a challenge, she rose to it. Her bones weakened and risked fracture, so we sent her for new hips. We sent her to the radiotherapy department to help with her pain. When pain became too complicated, we sent her for a nerve block, which she received at the interventional pain clinic within the hospice grounds. She was on a complex mix of medicines to keep her well and comfortable. She'd come to Marymount to get her problem sorted, and each time return home as quickly as possible to be in the centre of her young family. She became a gifted artist and held 2 exhibitions to fundraise in Marymount at Christmas time. She worked hard with her physiotherapist to maintain her independence. When she could no longer weight bear, she mastered an electric wheelchair and went home to a wheelchair modified house. Her end of the beginning lasted 5 years. She had in total 5 admissions to Marymount over a 5-year period. She lived a very active, full life despite her illness, albeit a little bit differently from how she lived before. I believe early support from palliative care helped her achieve this. She left a lasting impression on all who knew her and taught us much more about humour, courage and resilience. I'd like to finish on a metaphor which I've borrowed from Camilla Zimmerman, the researcher that I mentioned, operating out of Canada, out of St. Margaret's in Toronto. She proposes that we view palliative care as an umbrella to shelter us from the rain being the symptoms that we experience with our cancer, the symptoms we experience from and side effects that we experience from the treatments that we get, and all the other psychosocial burdens that it places on us. We propose that early palliative care may be presented metaphorically as an umbrella to have in case of rain. Unfortunately, the umbrella of palliative care is often conflated with the rain of symptoms, complications, and distress that occur during progressive cancer. So the first set of images depict what late palliative care referral looks like. Patients diagnosed with a cancer, a few months later, they're wet, they're suffering, they're in pain, they've no support, their loved one feels stressed. The doctor chases after them thinking, God, I should have given them the umbrella, I should have referred them to palliative care. Finally, they're referred and thank their consultant. Thanks, we wish we had this earlier to protect us from the rain. The second series of pictures depicts what it might look like should they have been referred a little bit earlier. So glad we had this when we needed it. Palliative care is the umbrella, it's not the rain. The trepidation that is evoked in patients at the mention of palliative care may be regarded as analogous to dreading the umbrella because of its association with the rain. The fear of palliative care stems from its association with occurrences that tend to be contemporaneous with the palliative care referral. Having cancer that is refractory to treatment, stopping treatment, focusing only on comfort and making a transition to hospice. To avoid patient distress, oncologists often delay referral to palliative care. However, this further delay validates patients' fears by reinforcing the connection of palliative care to end of life and makes the eventual transition much more difficult. So instead of avoiding that difficult conversation and perpetuating misunderstanding through late referral, oncologists can reassure patients that palliative care is the umbrella, it's not the rain. The rain represents the physical, emotional, and existential problems that may arise in the context of living with an advanced cancer. Palliative care is the umbrella that offers shelter in the event of rain. Confusing the umbrella and the rain leads to unnecessary distress and prevents access to a valuable resource that we've shown to improve quality of life. Thank you.
Thank you so much, Mary Jane. I have to say, Siobhan and I just said we love that metaphor. I'm sure everybody in the room does. It makes it easier to understand, doesn't it, and to accept. Yeah. So yes, everybody in the room now understands what palliative care means, and we're not afraid, and we shouldn't be afraid. Okay, I think it might be more pertinent to ask any questions of Mary Jane now before we do get Noel up to do something like exercise. Has anybody got any questions for Mary Jane?
Okay. Sorry, just bear with me a second.
Sure, I can share. How did we get the referral? Well, I was 2.5 years, nearly 3 years after the internet. I get all the support, I get my psychosocial and things I want from anything. You know, that's not the kind of thing. How do we begin with that? If not,
So you can ask your oncologist, if you're linked in with a clinical nurse specialist, your GP. So we receive referrals from physicians and also clinical nurse specialists. It's always interesting to most of patients are referred through their oncologist or through their clinical nurse specialist, or for some patients through their GP. But occasionally you'll have people like yourself who are requesting palliative care. And actually what I usually find is they're the patient who have been linked in some way with the service previously. So they'll have had a relative or a brother or sister or a friend who's gone through palliative care and who's been receiving care from palliative care, and they're the ones who get it, who say, actually, I need that as well. So that's very interesting. But you can be referred, you can ask for a referral. The referral has to come from your treating physician or your clinical nurse specialist. Yeah. But it's frustrating, isn't it? Yeah, and actually it's interesting because we always kind of quote the different barriers to referring to palliative care, and obviously you've got, the public perception and the fears around being referred and the patient barriers. But actually what we're seeing is the biggest barriers are the healthcare professionals. They don't know how to introduce the notion of palliative care, and they're afraid of the feelings that it might evoke in their patients. And they're afraid of upsetting their patient, or afraid their patient will lose hope if I suggest palliative care. And that was one of the reasons we did that study last year with UCC, to see how people are being referred, how are they being communicated, and what are people telling them about palliative care when they refer. So there's probably a gap in terms of the education we need to deliver to other healthcare professionals, in that this is how you bring up the topic of palliative care and this is how you introduce it. Yeah.
I think that's really important. It is hard to talk about sad news and the the Irish Hospice Foundation do some lovely work as well around, so that's really important. It'd be interesting to know how many people are with palliative care. So many? Not too many.
I'm on my first line of treatment, and thankfully I feel I'm on my first line of treatment, and thankfully I feel very well. But it's never been mentioned to me.
Okay.
In the hospital, no consultant has mentioned it, or no doctor, just for information. And one of your slides there said that you should consider referral when your first line of treatment fails. So do I wait until my Ibrance doesn't work its magic anymore, or do I go out and say I'm interested in palliative care because I have some bone issues or whatever?
Yeah, and the triggers for and I'm not sure whether Seamus, I feel like I'm going to get Seamus into trouble here. But a lot of the it's usually pain. Pain seems to be the kind of triggering kind of thing. Oh, I need to refer to palliative care because this patient has pain, and I think there's a lack of understanding of all the other stressors and complexities of care. Care needs not being met when you're living with cancer. The resources we have at the moment, I don't think we can see everybody and follow everybody that has a metastatic cancer. So that's why we kind of need what we're advocating for to begin with. Yes, we need more resources, we need more funding, and we had the launch of our new palliative care policy only a couple of weeks ago, where the minister launched our new palliative care policy and has promised more funding, but we need much more funding. So a starting point, we feel, is to look at patients that that really need it, in terms of, could we introduce a trigger referral system? So patients with cancers that we know produce more symptoms, cancers that we know they don't do as well. Are there psychosocial triggers, like patients living with young families, dependents who are working? So these types of triggers, to see if we could first get to the people that really need it, But knowing we'd love to get to everybody, but that's kind of where the system is at currently in Ireland, and that's where the resources are, and we need to advocate for more resources. Yeah. And I think that's where the model of dipping in and out comes in as well. We don't have the ability to follow everybody, but if we could just identify the people that need it, and I would absolutely advocate everyone living with a cancer should get it and needs it, at least meet them once and then know that we're there. And if you run into, even though you're feeling well this, for the next couple of months, maybe in 6 months time, you might feel unwell. And that's the time then that we need to step in. But once you're referred, then you can be kind of linked into the system appropriately. And again, we have a very kind of intensive nursing and doctor model, but at the moment we're kind of trying to reshape palliative care so that it's not all about seeing a doctor or a nurse, that actually, you're physically well at the moment, but you'd love to be enrolled in an exercise program. So instead of seeing the nurse and the doctor who don't have enough availability, that actually for the next couple of months that you enroll with our FAB program, which is our fatigue and breathlessness program, or you enroll with our Elevate program, which is our physio and OT program. So looking at the bespoke model that you might need a nurse or a doctor now, but actually what aspect of the service might you need at this point in time in your illness? Maybe it's the social worker, maybe it's the psycho-oncologist. Yeah.
Thank you so much. Thank you, Mary.
Okay.
Mary Jane won't be here for afternoon tea, but there will be plenty of us around, and if there's any questions that we can't answer, we'll be passing them on to
I'm
Mary
happy
Jane.
to give out my email if anyone wants.
Yeah. Okay. Thank you so much. Thank you. So we do have Noel in the room. So Dr. Noel McCaffrey, who, oh, sorry. Oh, yeah. Oh, yeah. So, founder and CEO of XWell. And I know some of you, it'd be interesting actually to know in the room who may have done an XWell program or are doing, oh yeah, quite a few. That's interesting. That's good, Noel. Good. Yeah, we're happy. So Noel is here. Noel has been here actually in this building before with us, and I think we kicked the football around for a while, and that was very interesting and exciting. But we've all heard this morning how important exercise is. But we've also, interestingly, when Siobhan, it's all about you today. The study, your study showed that 40% of people don't actually do exercise because they're afraid and they haven't been told or informed whether it's a good thing for them to do or not, and 40% of people do. So we're kind of here to learn a lot from Noel with regard to exercise, particularly in metastatic breast cancer. So we're going to hand over to yourself there, Noel, and thank you very much. I do believe we're going to do a little bit of exercise at the very end, but we'll be bringing Liz, our CEO, up to talk before that happens. Is that okay? So there'll be a shift in the room. Over to you, Noel.
Thank you very much. Delighted to be here. And just about the exercise bit at the end, it's completely optional. We can do it or not do it, depending on what you feel like. We'll take a little pause after the slides and we'll just move the chairs because we need room for this. Okay, so my thing is exercise for chronic illness, and over many years we've had a lot of engagement with cancer patients. Been very exhilarating over that period, and we've learned an awful lot about it. And the group we're talking to today, metastatic breast cancer, within the broader context of metastatic cancer, is particularly interesting to us because it's a group that was challenging and frankly ignored for a long period of time. And I'm aware of the new term metavivorship as opposed to cancer survivorship now, of people living for long periods of time with metastatic cancer, and that there are challenges and opportunities in that period to have a very enriching lifestyle based on many things, including exercise. Now, so I'm going to give a little bit of background about our work and about just healthy aging in general and the role of exercise in it. I'll give some information about general cancer stuff, and then we'll talk a bit about metabolic breast cancer, or metastatic breast cancer. And then I would just like to take a few minutes at the end of your time to just interact a bit with you to get your feedback about your attitudes to exercise and group exercise and exercising with or without other cancer patients, because there's some very interesting views on that. Okay, now, first of all, successful aging was defined back in the 70s as the absence of illness, basically. But the more modern definition that was introduced by the WHO recently enough is that it is the process of developing and maintaining the functional ability to do what you want to do. So that's for all of us. And this slide summarizes the trajectory of health that the normal, let's call it the normal population experiences, which is the black line of improved health into early middle ages, and then a gradual progression and a downward trajectory to ill health. And the difference between, let's call it normal people and masters athletes, is that the masters athletes maintain a higher level of health for a longer period. That's the light grey line. And then they have an accelerated, compressed period of morbidity towards the end. And the idea of clinical exercise programs is to shift the population from the black towards the grey. Now, in cancer in general, the role of exercise is interesting just to consider, because many people who develop cancer, in our experience, are very, very well before they get ill, and also very often very active before they get ill. And one of the big disappointments and sadnesses in the diagnosis of cancer is it's often accompanied by an abrupt withdrawal from exercise, which was fundamentally part of that person's identity. And it's an awful blow, as well as the sobering diagnosis, to no longer be doing what was essentially part of that person's nature. So one of the really important reasons to stay active from the outset is exactly to prevent that happening, to retain your identity. And the other important one at the outset is to continue to have an input, or to adopt an input into your own health at a time when all the decisions will be made by somebody else, that you have some sense of control. So that at all these stages along, at diagnosis, there's this confidence and retaining self-identity, which is wrapped up around staying active and exercise. Then during the treatment phase, your fitness tends to plummet very quickly. And the aim of exercise in that phase is to maintain it, not to get fitter, but to stop yourself getting unfit. And then around surgery, if there is surgery, we're trying to regain your fitness, to build you up for that operation, physically and mentally, to reduce perioperative complications, to improve psychological wellness, fear of surgery is reduced. There's also a peer support element to group exercise in preparation for surgery. And then in the recovery phase, moving back to your pre-cancer lifestyle, the moving on bit, patients over many years have told us consistently that having a group class to go to facilitates getting dressed again, driving again, getting out of the house again, meeting other people. And it's really, really important. And then for people who are on longer term treatment, those medications which are essential are often accompanied by side effects, some of which include increased risk of heart disease or cardiometabolic disease, and exercise reduces those risks. And then in the survivorship phase, there's that. And also the role of exercise may be reducing the risk of recurrence. And then we're at the stage of recurrence. And for people here in this room, some of you will have been through the phase of having had a diagnosis and treatment and then recurrence. And for some of you, the metastatic diagnosis may have been the first diagnosis at presentation. But there's then maybe a different focus on the role of exercise at this period. We'll talk about that in a minute. Now, so just to summarize that, during the treatment phase, there's your fitness before you get a diagnosis, and there's your diagnosis. And then what happens is it plummets during the treatment phase. And we try to interrupt that by exercise. And then when the treatment finishes in the pre-operative phase, we try to build you back up again to get you where you were, or even higher, at a higher level of function, to prepare you optimally for that procedure. Then afterwards, in the recovery phase, the immediate post-op phase, there may be a dip again as a function of bed rest or inactivity or whatever. And then we, hopefully, by intervening quickly with rehab, enhanced recovery, we get you going quickly and your fitness goes up again. And then in the longer term, in the survivorship phase, we hope for that by maintaining an active lifestyle. And some cancers behave like long-term illnesses, like the myelomas or prostate, where it is like a chronic illness. And there is this increased evidence of people surviving for long periods with metastatic cancer. So there is a body of people that fall into the category of living with metastatic cancer for long periods. And then here, when you get a recurrence, if it does happen, it's likely that fitness will disimprove, and it may slowly disimprove further. And the role of exercise for this group, which is this group, is to make that period enjoyable, fulfilling, to remove the fear of exercise, and to try to give people the opportunity to stay active in whatever way helps. Now, just very briefly, this is a famous study from, this is about mortality in people with colorectal cancer, the nurses study in the States, which looked at the effect of changing exercise behavior through the treatment phase on mortality. So the 3 bars on the left represent the mortality experience of 3 different groups of people, mortality from the cancer. And the bar in the middle, which is a value of 1, is the mortality rate given to those people with colorectal cancer who did not change their exercise behavior from start to finish of treatment. The bar to the left of that is the mortality rate experienced by those who became more active, and it's reduced. And to the right of that is the rate experienced by those who became less active. So there's an increased mortality from the cancer in people who became less active. And the 3 bars on the right show the very same data related to all-cause mortality. So increasing exercise behavior, as we all know by now, is linked with reduced mortality. Now, this slide, I'm going to just show it and then take it away, because what it is a really interesting summary of studies that looked at the effect of exercise on the risk of experiencing pulmonary complications in the post-operative period, no matter what the operation. Many of them are for cancer. And basically, that line over there, so the column with the figures shows the number of studies relevant to the data point to the left of that line. And if the data points are to the left of the line, it signifies that there's evidence for a reduced risk of getting pulmonary complications. Now, what I just want to summarize for that is that what that study shows, and it's recent, is that no matter what the surgery is for, no matter what it's for, including cancer of almost any type of cancer, no matter what type of training is done, whether it's aerobic training, strength training, interval training, no matter what it is, and no matter how long it's done for, including if it's only done for a week, there is evidence that exercise pre-surgical reduces the risk of post-operative pulmonary complications, the type of complications that kill you, the pneumonias, the lung clots. That's amazing evidence for the role of exercise of any type, for any duration, for any operation in enhancing your health. Now, so the rationale for exercising in metastatic cancer, it's to maintain function, it's to help with symptoms, and we've heard about pain and fatigue earlier on. It's to bring enjoyment, it's to restore self-identity and some element of control, that I'm doing what I want and it doesn't matter who tells me what, this is what I like doing. And we have had experience in Exwell of people with metastatic breast cancer, with spinal deposits, where there is sort of a tendency to be very careful about rotational activity, for example, who have said, look, I know this is not good news, I just want to do it. In which case, they should do it, in my opinion. And very commonly, the biomechanical impact of a spinal deposit is not significant. It does not commonly induce frailty necessarily. The fact that you have a deposit does not mean your spine is suddenly about to disintegrate. It does not mean that. And we'll take advice from the orthopedic surgeons or the oncologists about a given patient, but it is not the case that exercise that they may enjoy, jigging around for a bit of dancing, that they can't do it because it involves rotations. Now, this I came across this week when I was getting ready for this talk, that This is a quote from a patient with metastatic breast cancer. When you learn you have metastatic cancer and see the survival statistics, it can be overwhelmingly emotional. And if you're living with metastatic cancer, you're living from treatment to treatment, from scan to scan, and it can be fraught with just that anxiety about what will the next result show. So a couple of studies just to report on attitudes from patients to living with metastatic breast cancer. Okay, so here's from Louise, 2015. Based on in-depth interviews, 3 main themes arose as of concern to patients with metastatic breast cancer. One is trying to get over it and become normal again. The second broad theme was that's not going to happen, to reevaluate, to reset, and to find a new sort of set of priorities given the new realities. And the third main theme was the trauma and distress around acknowledging and processing and coming to terms with sustained reduced capacity to live because in the way they previously did because of symptoms. Another study looking at in-depth essays provided by 44 people about their experience of living with metastatic breast cancer, that 3 main themes emerged here. One is quality of life, physical symptoms, emotional distress, all that, body image disturbance. The second was the difficulty of communicating about their illness with other people, and that maybe people here would recognize that. I think we've all come across situations where an acquaintance has a difficult situation of some sort, and that person's acquaintances struggle to just have the ability to talk about it to that person and almost cross the street to avoid them, to not have to do that. And it's not because of badness, it's just because that person doesn't have the skills to actually engage in a way that would be very emotionally helpful for the patient. But that is reflected in point number 2. And then there's a third point, that many women experience heightened awareness of life's brevity and search for meaning in their cancer experience. And that's a theme that reflects the concept of maybe trying to find joy and purpose and happiness in a new situation. Now, the challenges of exercise in cancer patients include the symptoms, frailty, fatigue, pain, the idea of bony mets, motivation, and sometimes the very sensible, well, what's the point of exercising if I'm at this stage of my journey in cancer? And this study looked at the input from focus groups across 4 EU countries, 44 participants, mainly with bone and liver spread. And the main comorbidities that these people had were back pain, high blood pressure, and depression. And the emerging themes from these interviews were the importance of a positive attitude exercise, that these people didn't have any preference for what type of exercise they did in general, but they did have a preference for personalized programs. But at the same time, they liked the group environment, and there's a conflict there. And they like the idea of supervision. And just to go back to those 2 points, what I mean by that conflict is that the work I'm involved in is chronic illness rehab in general, and it's a big numbers game. You know, we have a big project which is in 40 centres and it's 6,000 visits a week and 50 people in a class. And the prospect of individualised programs is just not a runner. It just does not work. Even though in concept it might make sense. Now, with a metastatic breast cancer patient, that will be a smaller cohort. There may be more room for exactly that. But even at that, if you're dealing with more than 4 or 5 people, having 4 or 5 people doing different exercise programs in the same class in a coherent way is a challenge. It is a challenge. And in some ways, we've come to the view that it's not necessary, because it's possible to crudely grade exercise as gentle, standard, or advanced. And by having those crude categories, it covers most needs. unless there is a specific challenge for a person. And even at that, it's usually possible to accommodate it without having to get out to one-to-one. That's our experience. At least we can't offer that. Now, even people with treatment effects like peripheral neuropathy who are a bit clumsy on their feet because of the effect of their chemo, it doesn't mean they can't exercise. We just need to know they have it, so that we're not asking them to do silly things like running backwards, which is likely to provoke a fall. But that sort of person is very safe on an exercise bike where they're holding on and they're not going to fall off it. You know, so the exercise bikes may be a part of our general setup anyway. So it's possible to accommodate most people, I wouldn't say everybody, but most people in that way. So the barriers that are identified are the physical limitations from the disease or its treatments, and there is the issue of suffering, fear of suffering harm. And it's for us to find a way to reassure people with the supervision, with the environment, with a graded approach, easing into it, that this is not necessarily harmful. Or I cannot remember, actually, in 20 years working in this field, having had a negative experience with an episode in a class with a cancer patient, including metastatic cancer patients. So this was a recent study looking at physical activity for symptom management. An RCT 14, that's a randomized controlled trial, exercise versus control, and the exercise was 2 per week supervised classes using strength work and also unsupervised walking on the other days. And basically it was well tolerated, no adverse events, with improvements in fatigue, pain, aerobic fitness, and in social function. And this was another patient perspectives study done in 23, looking at 420 patients across 5 EU countries, 70% of bony mets. 68, nearly 70% of them felt competent for aerobic exercise and less confident and competent with regard to strength work. That wouldn't be that unusual because people are more used to doing aerobic exercise anyway than they are used to lifting dumbbells or kettlebells. Or the barriers that were identified were no access to a local program, feeling of weakness or fatigue, and the facilitators that tended to prompt people to take part were a previous positive exercise experience and personalized advice. These patients expressed a preference for walking and for public gym. And at the same time, when it comes to paying for it, that's also a barrier. And very few people would pay more than €50 a month for a program. And if a program is twice a week, 8 classes, €50, $650, that's not a lot to be asked to pay for certainly commercial classes, but it is a barrier. Now, so the service delivery issues for us in Exwell are individual versus generic. We mix it a bit. In some of our centres, we have enough people with cancer to form a cancer group in that centre. In some centres, we don't have enough. The exercise offering that they get is the very same. It's a mixture of aerobic exercise, balance, and strength work. It may be as part of a broader group, or it may be as part of a cancer group. The advantage of the broader group is that some patients with cancer are sick of talking about it. They don't want to meet anybody else with cancer. They want to be in a, let's call it a normal group. And the other benefit of it is that they get inspired by seeing other people with other illnesses struggling with their own challenges and getting on with it and doing fine. And it distracts them a little bit from the focus on cancer. By contrast, in the cancer specific group, the feeling of support is marvellous. And also, the cancer patients in general tend to be a bit younger than the people that we work with. They're more comfortable in that group. So there's no right answer to that. It depends on the environment. I remember in one talk a few years ago being told by a cancer patient what I said earlier, that she would not dream of going to a cancer class because she just did not want to see anybody else with cancer. And she was at a stage where it wasn't clear which way she was going to be in terms of progression. And she did, by seeing people with advanced cancer, that's very depressing, you know. So I'd love to hear some views on that, because that sort of feedback informs how we set up services, and it's really, really important. So we've just spoken about that. And the cancer specific classes, I've just gone through that. Okay, so I think what I'm going to do is I will stop, and because I want to leave a bit of time now before we hand over to Liz for comments. I'd love to hear, does anybody here take part in exercise regularly at the moment? And can I just ask, would you prefer to be doing that in a cancer group or not? Any comments on that from anyone? Sorry? Both? Both?
Yeah.
Right, okay.
As in, maybe a class a week with just regular class and then another class with cancer
Okay.
patients.
Any other comments on that?
Sometimes
Sorry? Mixed. As this speaker said, the same. Sorry, mixed with other people who don't have cancer. Now, are you saying that within Exwell you found that off-putting? Yeah. Yes.
Any relevance to anything about experience at all.
And did you feel that was just age related or disease related?
There was a little bit of both, a little bit of obviously, the IWA.
Yeah.
Very few to cancer and young patients.
Yeah.
Again, it's just our ability and what we would like to do are sometimes different to what the needs and profile and desires of people are.
Yeah. And you know what, you're dead right. You're absolutely right. And you've touched on something which is not specifically unique to cancer, which is age in the external environment, because younger people in their 30s or 50s, let's say, exercising in a group of people who are over 70, it's a challenge. Now, some people don't mind it and some people do mind it, but it's a really important point you've raised. Separately from relating to people around the illness, which is also relevant, but it's relevant from both perspectives, it being a good thing and also being maybe a good thing to meet people with other illnesses, right? So there's a few very interesting points there. Thank you for that.
I've been to your classes as well up at Helen Leisure Centre, and I have to say they were very, very enjoyable, and I did enjoy the mixed class. But I agree with some of the ladies, if you went to a cancer-centred class every now and then, just to be sure that you're doing everything correctly.
Yeah.
But the only thing I found was, because I was in a class with other people who were quite immobile, that I'm quite healthy and fit, that I was pulling 100%. So they said you've got 10 minutes, you to run down the line here as many times as you possibly can. So I was taken off, and the others were only on little walking sticks, anything. So I was taken off, and I was running around, and I was burning energy, and then we were doing the weight and all the other bits and pieces. By the time I left the class, I was absolutely drenched, but I was using up too much energy.
Yeah.
And I found I was getting dizzy spells, so I had to get up going because I was getting so dizzy.
Okay, also very interesting. And you've touched on another issue there, which is people have different abilities within the same class, even if they're the same age. So there's age, there's functional ability, and there's illness. There's three different factors to bear in mind here. And we have a separate challenge in Exwell about addressing the age thing by offering the very same programme to an age band that is, let's call it younger, and younger means less than 55, let's say. So it's a really interesting point. It's a really interesting point you raised there. Although I would say that we should have taken you to task and say, just slow down a little bit. Yes, true. Okay, maybe we gave the wrong instruction. There's a lady over here in the blue hat.
Since the start of the year, and I used to do the general classes. I know folks exercise classes. Apologies to the others, but recently have started to move on ones which are the cancer specific. months, just because the timing has now worked out well for me. And I have to say they're brilliant because I'm coming in, I'm at a different stage. Some people are 2 years past their treatment, others are in their treatment, but I know that I can do the weights according to me, and I'm recording it, and I know the instructor is there if I have any questions, or just, you know, she's saying don't push it, or you just had treatment, you know, you had it last week, don't push yourself today, you know, so
Yeah,
there's
okay.
good, but there's also good camaraderie with the other women, and there's a, you know, there's a man
Right.
occasionally turns up as well, for, you know, just that we've all been through cancer treatment or prognosis.
Okay, maybe rather than drag it on, thank you so much for that, because I'll take note of them. It sounds to me as if the consensus here slightly might be towards having at least the ability to go to cancer-specific groups, maybe not all the time, but at least an option on a regular basis. That sounds like, okay, great. Now, I think I'll take an executive decision to stop and hand over to, I think, Liz wants to come up. Am I right?
Yeah, I'd like to invite Liz up to the podium here, our CEO, who is very welcome. Obviously, you've been here all day supporting us all. So Liz, I'm going to hand over to yourself there, to say have some closing remarks, I guess. And
Just move that slide, sorry. I don't see slides. You'd be glad to hear I don't have any slides. No, I'm just wrapping up what has been a most enormously informative and inspiring session. We started the Metastatic Breast Cancer Awareness Day together with Europa Dama. I think it was 9 years ago. Helen and I did our first one, and I think we possibly had maybe 20 people in the room, if even. And every year we've gradually seen more and more people joining the community. And I think Positive Living as a metastatic cancer group, it started off as just breast cancer, but has now grown, including the people living with other types of metastatic cancer. And that was born out of the MBC Awareness Day. And that is going from strength to strength, as many of you here will know. I see a number of new faces in the room today. You're all most welcome. It's wonderful to see partners and family members joining our MBC ladies and Positive Living ladies here as well. And for those of you who are new, please do check out our Positive Living group. It's facilitated by Helen. Every week, every month, there's a different focus, and everybody in the room is affected by metastatic cancer and shares all of the issues and needs that have been highlighted by Siobhan's amazingly inspirational study and survey. And it's very much focused on you and your needs and your and how the Marie Keating Foundation can support you. We call it Positive Living. I mean, the ethos of the Marie Keating Foundation is to make cancer less frightening by enlightening. I think we've been enlightened today, we've been informed. Siobhan said it earlier, information is power. We've learned so much, and I was just so struck how uplifting every single one of the speakers were today. I mean, starting off with Louise and the National Cancer Control Programme, and that focus now that is beginning to really emerge on survivorship, the Alliance and the work that the Alliance are doing around Ireland in supporting cancer survivors, but also increasingly and more so, hopefully, patients living with advanced disease. And I think in terms of policy change, and now that finally the government has assigned budget specifically to cancer care in this year's budget and next year's budget, and we will continue to advocate that that continues. And I think with the timing of the next cancer strategy coming, we will ensure that we're all jumping on your team, Siobhan, to advocate to ensure that all of those recommendations are brought to the Department of Health, to the NCCP, and that together as cancer organisations, as patient advocates, and that we form a very robust alliance to put those recommendations into practice. So Seamus, I think, you know, to hear from you, I'm so uplifted because, you know, you talk about the explosion of new cancer treatments, you know, it is really transformational. And, you know, to see people coming back here again and again, it is really inspiring. I think we've one lady in our positive living group who is living more than 14 years with metastatic breast cancer. You know, that's so inspiring for newcomers to our community to know that the treatments are improving and adapting so readily. It really is transformational. And then to ensure that you know, the organisations like the Marie Keating Foundation, it's wonderful to see ARC, Rochus, the Irish Hospice Foundation, and to hear about the palliative care, the importance of exercise, the importance of all the other lifestyle factors in ensuring that people are living their best lives, living well with metastatic disease. It's truly been a positive, an uplifting, an inspirational day, and also want to really congratulate Sean and all the patient advocates here who took part in that study. I mean, as was said earlier, to get that from A to Z within such a short time frame and to be patient-led, I think to me, as a former patient as well, knowing that this is really the voice of the patient being articulated so well, and with the support of the oncology community and other healthcare professionals, congratulations. No, it really was truly inspiring. I want to just thank our sponsors as well. So AstraZeneca, Novartis and Pfizer. Again, we're a very small organisation at the Marie Keating Foundation team. We couldn't have done this without you. We couldn't continue positive living without your support. And it's wonderful to be partnered for so many years with you, and we hope to continue that partnership and really looking again at the specific needs of the metastatic community and seeing how we can advance those with your support. To all of our speakers, thank you so much for being here. It has really been so informative, really inspirational and so positive. I'm coming away very uplifted. I especially loved the Celine. There are people who are not with us today who we dearly remember, and we started the day on a very emotional note. They're in our hearts, we will never forget them. And just to our own team at the Marie Keating Foundation, so Jane, Kathy, Liz, I think a third of us are here. We're a small team, but I think about 6 or 7 of us are here today. Jane, Kathy, Lisa, Liz, Bernie, Fiona, who's been so much of she's played such a big role in positive living in general and coordinating that over the years, but also in terms of managing that and administering everything for today. And last but not least, and on your behalf, I would like to pay a very special tribute to Helen. So Helen and I are both joined the foundation 10 years ago. We work very closely together, and I don't think anyone could lead the positive living group as well and as with such sensitivity, with such expertise, with such passion and commitment. And that is not just a positive living, by the way. Helen does this across our whole range of nursing services. So Helen, a massive thank you to you. It's a privilege to work with you. And thank you so much. We will be going down for afternoon tea now. I'm sure everybody's tummies are rumbling. And just Siobhan, I might just hand over to you.
Helen doesn't know anything about this, by the way. We ganged up in the background, all the ladies of positive living, because the truth is, without Helen, we wouldn't be here. Genuinely, without that level of support that she provides for us day in, day out, by the way, none of the work that any of us have done or continue to do would actually be possible. So she's the platform. And we just wanted to mark a very special birthday that Helen's having in October, in a week or two. Happy birthday, Helen, from all of us.
Thank you so much. I'm 50, okay? And I don't know who let the cat out of the bag. Who was it? Thank you so much. These are beautiful. That's all I'm going to say.
There's an envelope in there.
Okay. Thank you. Do we want to exercise? We'll have how many minutes of exercise will we have? And then we'll move downstairs.
Could we compromise it?